Hello everyone, we have started this crash course series for PDCET 2023 Obstetric and Gynecology students. So this is a demo lecture and we will cover few important topics in this one. All our lectures of the crash course would be more or less like this only, and we will present topics in the form of bullets, and a small lecture will be taken on Zoom meeting, and after completion of the meeting, those students who have enrolled in the crash course, we will also provide the PowerPoint presentation of these lectures to them. Okay, so fastly we will complete this lecture. First is about some basic points about fertilization. Fertilization occurs in the ampulla of fallopian tube. Now one point I need to mention here, that all of these points are previous year questions or very important points of this subject, and have been asked many times previously in different exams, PG entrance or other exams. So none of the line is not useful. Every point is important for your examination. Okay, and you have to read in this pattern only, NEET PG pattern, because now the time is very less. You have only 1 month left with you, and it's not possible to read all the standard textbooks of obstetric and gynecology. And the main thing is the exam pattern is MCQ. So you need to sharpen your theoretical points also, and these points even after doing diploma in a particular subject, we get a good knowledge about the clinical aspect, but it's not. So we will continue here. So the first point was fertilization occurs in ampulla of the fallopian tube. This question has been asked previously many times. Sperm binds to secondary oocyte. The site of implantation is posterior superior wall of the uterus. What is decidua? Decidua, the endometrium of pregnant uterus, is known as decidua. Part of decidua. So these three important points for decidua. The parts of decidua in contact with blastocyst, it's known as decidua basilis. You can remember B for B. Part of decidua covering ovum is decidua capsularis, that is a capsule, the covering of ovum, and the remaining decidua outside implantation area is decidua paritalis. So these are the important points for decidua. Next is events following fertilization. Like if we consider that fertilization has occurred at 0 hour, so at 30 hours what happens? 2 cell stage blastomere formation takes place. At 96 hours, this one is very important for exam, at 96 hours morula formation takes place, which enters the uterine cavity, and it is 16 cell stage. So questions can be framed in these manners, that which structure is formed at 96 hours of fertilization, then answer will go as morula. Which stage of embryo enters uterine cavity, then it's morula. And how many cell stage is morula? So it's 16 cell stage. At 5th day, blastocyst formation. Now important one, 6 to 7 day, what happens? Zona pellucida disappears. It's very important for zona pellucida to disappear for implantation to occur. So zona pellucida disappear and interstitial implantation occurs at 6 to 7 days. Now at 10 to 11 days, implantation completes. So this MCQ question can be confusing. If question comes that interstitial implantation occurs at how many days after fertilization, so answer will be around 6 to 7 days. And if question comes implantation completes after how many days, so answer will be 10 to 11 days. At 21 to 22nd day, fetal heart forms and fetal placental circulation begins. Now the different placental variations. This is bilobe placenta, 2 lobes, circummarginate, battledore, velamentous, accentuate, and circumvallate. So image based questions are also important, so go through these images. This is the description about them. Accentuate placenta, what happens? Small part of placenta separated from the rest. So this one is accentuate. This is small part of placenta is separated from the rest. Okay, and fenestrated, name suggests placenta has a hole in the center. Circumvallate, the edge of placenta is covered by circular fold of deciduars. So this is circumvallate placenta. Now next is marginal battledore placenta with cord attachment to margins. The name suggests marginal and battledore, the cord is attached to the margins. So this is battledore insertion. Last is filamentous insertion. What happens? Blood vessels attached to amnion where they ramify. Just remember important term, ramify, before they reaching the placenta. So this is filamentous. The vessels are ramifying before reaching the placenta. So this is filamentous insertion. These are the types of placentas. And now important points about the placenta in humans. Many questions have been framed in previous years. So there is interstitial implantation of placenta in humans. The type of placenta is hemochorial. The diameter is 6 to 8 inches and the weight is around 500 grams. Now there are two fetal cotyledons and maternal cotyledons. So fetal cotyledons are 60 to 100 in number, while maternal cotyledons are 15 to 20 in number. Okay. And this Nitabox layer, question has been asked in PGI entrance few years back about Nitabox layer. The question was like this. This statement was given that zone of fibrinoid degeneration where trophoblast and decidua meet is known as. So there were four options and one option out of those was Nitabox layer. So Nitabox layer is zone of fibrinoid degeneration where trophoblast and decidua meet. Placental circulation is established on 17th day of fertilization. Placenta has two arteries and one vein. Left vein is left, right disappears. What are folds of Hoboken? Folds of Hoboken, where are they seen? They are seen in the umbilical cord. So these are theoretical points, and after even learning the clinical aspect of the subject, we are not masters of these points, and the questions in these competitive MCQ based exams arise from these theoretical points only. So they might look useless or they might look easy, but these are the points which are rank deciding sometimes, because clinical case history based, case scenario based questions you might be able to attend quite nicely after completing your diplomas, but these theoretical questions you have already 2-3 years have passed when you last read for NEET PG. So these points are very much important. You have to put stress on these points. Okay, now what the difference between types of placentas? The placenta accreta spectrum. This is in normal pregnancy. Normal placenta is the placenta attaches to the temporary layer in uterus that shades at delivery. So this is normal placenta. Now there are three terms: accreta, increta and percreta. So what happens in accreta? When the placenta attaches too deeply in the uterine wall. The placenta is attaching too deeply in the uterine wall. This is in accreta. In increta, the placenta attaches into the uterine muscle. And in percreta, what happens? The placenta goes completely through the uterine wall, sometimes invading the nearby organs. So placenta is invading the nearby organs and just completely going through the uterine wall. So these are three types: accreta, increta and percreta, in the increasing order of severity. Increta is more severe than accreta and percreta is the most severe one. Okay. Next is placental hormones, important topic. HCG is a very important placental hormone. Human chorionic gonadotropin. This is glycoprotein. Just remember this is glycoprotein and have two subunits. First is alpha, second is beta. Alpha subunit is hormone non-specific and beta unit is hormone specific. Why alpha unit is hormone non-specific? Because it's chemically similar to LH, FSH and TSH, while beta subunit is specific to HCG. HCG is synthesized by syncytial trophoblast, and the half-life of HCG is 1.5 days. So these all points were asked somewhere, sometime in previous year exams. Now the HCG is detected in maternal serum by radioimmunoassay as early as 8 to 9 days following ovulation. The doubling time in plasma, okay, it's 2 days. The maximum levels in blood and urine, you need to remember. In blood the maximum level is 100, in urine the maximum level is 200. B comes before U, so B, the maximum level is less 100, and urine, the maximum level is 200. Okay, it disappears from circulation within 2 weeks following delivery. So remember these important points about HCG. Next is HPL, that is human placental lactogen, also known as human chorionic somatotropin. It's synthesized by syncytial trophoblast. It promotes, what is the function of HPL? It promotes growth hormone release and insulin secretion, but it decreases. One word is missing here. It decreases the peripheral effects of insulin, hence increases the insulin resistance during pregnancy. So HPL is one of the reasons of the increased insulin resistance during pregnancy. What is the other role of HPL? It stimulates the mammary growth. If the level of HPS is less than 5 mg per ml after 35 weeks of gestation, then it suggests fetal distress. Next is pregnancy specific Beta-1 Glycoprotein. It is produced by trophoblast, detected in maternal serum by 7 days after ovulation. So earliest it is detected, pregnancy specific Beta-1 Glycoprotein, and hence it is used as a specific test for pregnancy. Another hormone is estrogen. It's secreted by syncytial trophoblast. Synthesis depends on the precursor derived from fetus. So question can be framed like this, then that the synthesis of which of the following hormone is dependent on the precursor derived from fetus. So options will be estrogen, HPL, HCG, all of the above. So you have to choose estrogen. In late pregnancy, most important estrogen is estriol, and increases secretion. What estrogen does? It increases the secretion in ciliary beating in fallopian tubes. It also changes the lining of vagina from cuboidal to stratified. Okay. Estrogen breakdown of glycogen into lactate in vagina. It initiates the development of breast and it causes early epiphyseal closure and causes retention of water. Progesterone is synthesized by the syncytial trophoblast. It is the main hormone of corpus luteum and it maintains pregnancy. Its level decreases rapidly after delivery and is undetectable after 24 hours. So just remember this, that level of progesterone is undetectable after delivery after how many hours or how many days? 24 hours. Okay. Now next bullet is for amniotic fluid, the gestational age and volume. It's quite controversial, but mostly you have to remember this only, that at 12 weeks it's around 50 ml, at 20 weeks it's around 400 ml, at 36 weeks it's a maximum around 1000 ml, and at term it falls to 600 to 800 ml. And the amniotic fluid is replaced every 3 hours. This question was one asked in JIPMER. And different colors of amniotic fluid and different conditions. So the green color with fetal distress, golden color with RH incompatibility, saffron color seen in post maturity, and dark brown color of amniotic fluid is seen in IUD. So this was a short lecture, just a demo lecture, and we are going to conduct the crash course for obstetric and gynecology with almost 10 more lectures and with detail, and we'll cover fastly because the time is very less now. Only about a month is left, even less than a month, so we need to cover the important points only. It's not possible to read each and every theoretical point of whole obstetric and gynecology. So the most important points from each and every topic, as much as we can cover, we will try to, and the most important questions asked in previous year exams. So this is a basic plan. So if you are interested, you can subscribe to our course, and everyone please try to read well. Thank you.